Hi everyone, my name is Josh Scott, and I am the CEO and founder of Guardian Recovery Network, and I am grateful to be here presenting at our first annual Guardian Symposium. The topic that I wanted to speak about today is intervention through connection. And intervention is a critical component not just of addiction treatment, in my humble opinion, but it is also very closely woven into the very fabric of what Guardian Recovery Network is and where Guardian Recovery Network came from. I had the opportunity in 2005 to begin a small private intervention practice. It was myself and one registered nurse. And we would travel around the country and work with families that had loved ones that were resistant to treatment but in crisis, and help the family systems find a path to get their loved one connected with care and to help support both the patient and the family system throughout that journey into recovery. Over the last 15 years, we've had the opportunity to grow Guardian Recovery Network into where we are today, which is an organization with nearly 400 full-time employees and facilities in Portland, Maine, Princeton, New Jersey, 2 facilities in Florida, and we're currently weeks away from opening in Denver, Colorado. We have a few other sites on the horizon, but that is a very quick thumbnail of where we are today and how we've gotten to this point, being really closely tied to that intervention process. The first several years of my work in the field was intervention only and working with families throughout the United States and even outside of the country. As it pertains to, so let's get into a little bit of the intervention process and what that is and where the connection comes in for me. I believe, and some of what I say today is going to be my personal belief, my professional experience, not necessarily the textbook fact of behavioral health care at large, but my personal opinion is that 100% of patients that enter the doors of a treatment program, and recovery for that matter, 100% of those patients enter through an intervention. And what I mean by that is not all those interventions are professionally facilitated, but I have not yet met a person who walked into a treatment program because they thought it was a good idea following a great weekend or a great year. Everyone that I've ever seen enter treatment, even when they enter quote unquote voluntarily, they're doing so because something has gone wrong. Some fact of their life has changed significantly and they are uncomfortable and looking for a different outcome. Sometimes those interventions are legal, driving under the influence, arrest. Sometimes those interventions are health related. Someone has an overdose and finds themselves petrified that their addiction is bigger than they are. Sometimes those interventions are financial. Someone finds themselves in financial straits and is unable to meet their financial obligations. And sometimes those interventions are family related, not professionally facilitated, but you'll have a marriage that falls apart or children that estrange themselves from an alcoholic or drug addicted parent. And in those events, individuals that are struggling with addiction may find themselves at a point where recovery and treatment seems to be the best option. The intervention work that we do is working with families and through families to help design what I call controlled interventions. The interventions that I just described are what I would call interventions in the wild or uncontrolled. But a controlled intervention is when a family system with professional guidance thoughtfully and intentionally designs a conversation and a restructuring of the family system in such a way that an individual finds themselves at what we oftentimes refer to as that bottom, or the touchstone moment where someone is in enough discomfort that they've decided that they want to get help. Now, these interventions, as I like to work with families around, aren't about creating discomfort for the patient, but they are about allowing the patient to find and experience the discomfort that they themselves are creating for themselves. And what I mean by that is addiction is irresponsible at its very nature. Being intoxicated runs counter to what life expects of us to meet the responsibilities that come to us as adults. We're responsible to families, we're responsible to our careers, we're responsible to our friends, we're responsible to take care of ourselves in various ways. When we are in active addiction, when an individual is in active addiction, they are unable to meet those responsibilities reliably and consistently. So what happens if, as adults, we don't take care of our responsibilities? What happens if we don't pay our taxes? What happens if we don't show up at work? What happens if we don't feed and clothe ourselves? What happens if we don't take care of our immediate family or are not available for connection with our immediate family? Well, the world would start to fall in on us. If we're not showing up at work, we lose our job, and for almost all of us, that would be considerably problematic. If our family moves away from us and can't relate to us, that would be problematic. So what the addicted individual tends to do, and this is some of the core understanding that I ground myself in when I begin the intervention process, is to understand that the addicted individual, to support their addiction and continue in their addiction, has to hand off their responsibilities to a system around them. And that system is comprised of the people closest to them: family, friends, the people that care about and love an individual. As that family takes on those responsibilities, what they're actually doing, and this is a word that you'll hear from time to time, I choose to not use it with families. You'll hear the word enabling or enabler or codependent. I stay away from that with families, the language of that, because the language of that, in my experience, is something that families have oftentimes been beaten up with by people around them, by their peers, by other family members, and in some instances even by therapists and counselors. And it brings with it a pretty negative connotation, which is that the family is somehow responsible for the addiction, or at least the continuation of the addiction. And instead of responsibility, what I like to talk about is, when I'm working with a family system, one of the key things that I need the family system to shift. In virtually every case that comes to me where someone is in crisis and a family is asking for help, the family's dynamic exists in that system in a way that is, in some ways, and I'm gonna tiptoe around the words here, because I do believe that language is very important when we think about this and when we do this work. But the family system is in some ways allowing or giving space to the addiction, and allowing in turn the addiction to continue, worsen, progress. So the work that I like to do is to help families understand their role prior to the intervention, what has happened historically in the family's role that has been helpful, and what has happened in the family's role with their loved one that has perhaps not been helpful. And when the family is able to conceptualize and understand that and really internalize it, move it from here to internalizing their role and what their role has produced, how their role has affected their loved one, then we're able to make those changes. And we're able to make those changes without judgment and without guilt or shame from the family members in many instances. Whereas when we approach a family and talk to them about their enabling patterns or their codependency, the families, in my experience, tend to wall off. They've heard this before. They've, as I said earlier, have been beaten up by these words. And that creates a situation with the family where the family doesn't find openness and willingness and the receptivity to understand a way that they can restructure their family dynamic. So the process that I really like to describe to them is instead of using the language of enabler and codependent, is to describe to them the actual process that is behind that, the dynamics of actually loving someone that is in crisis without knowing how to help them out of that crisis, and in those moments making the decision to use whatever resources we have at our disposal to help our family member as best we can. An analogy that I like to use is if a mother and father of a 21-year-old son that was suffering instead of addiction but from cancer, also a medical diagnosis, a disease that is progressive. Once an individual's been diagnosed with cancer, without treatment, it gets worse over time. It is fatal if untreated in many instances, and it is chronic. Once you have the diagnosis, even once you have achieved remission, it is possible for that diagnosis to return. So if the parents of a 21-year-old young man that had cancer were interacting with their son and supporting their son through his cancer, and because of the symptoms of his cancer, he was unable to take care of his financial responsibilities. He was unable to maintain a job. He was unable to go to school. He was unable to pay his bills and feed himself. If that mother and father showed up day in and day out and did his laundry for him and cleaned his room and gave him a car to drive and took care of his bills, those parents would be doing the loving, natural thing, and those parents would be wonderful godsends. But if you adjust that from cancer, that system from cancer to addiction, and the families did the same thing, had a child that they were worried about from year to year if they were going to survive, had a child that, because of the symptoms of their illness and diagnosis, were unable to take care of themselves. If that family dug deep into their chest of resources and used their financial means and used their time and energy to make life easier for that individual, if they took on that individual's responsibilities, we would call them enablers. We would potentially call them codependent. We would potentially point to them that what they're doing isn't working. And what I've found to be more effective is to instead share even that exact analogy with a family system that is in the middle of dealing with a loved one with active addiction, and to point out to them that their instinct to help, their love for their family member, is actually what is driving their use of their resources to support their loved one, but with addiction, that it is counterintuitive, it is sinister, and that those same resources that a family member gives to a loved one that's struggling with addiction actually allows the addiction to metastasize, actually allows addiction to worsen. And it's oftentimes not until a family steps back and removes themselves from that dance, from that dynamic, that their loved one experiences what we talked about at the beginning of this short talk, which is that it is when someone experiences a shift, a consequence, that they then become uncomfortable enough that treatment and ultimately recovery is the easiest option. That treatment becomes easier than watching yourself fall into financial ruin. Treatment becomes easier than having your wife walk out of the marriage. Treatment becomes easier than having your children no longer talk to you and having to live with that. So when families are able to understand that the love and caring that they have for their loved one drives them to use their resources to soften and take the responsibilities on of a loved one that's struggling with addiction, when the families understand that and can shift and take a step back and put themselves in a position where they are allowing the individual struggling with addiction to experience the consequences of their addiction. I don't subscribe to what I've seen in some intervention methodologies of looking for ways to make life uncomfortable, looking for ways to look, son, if you won't accept help, then we are cutting you out of the family will, or we are taking away these things that you want. You can't come to our house if you don't get help, because we know how much you like that, coming to our house and eating with us once a week, but we're cutting you off. You're not allowed on our property because we want to make it uncomfortable for you. That I also feel is counterproductive. I think that the approach, while it may sound similar, I think the approach that works better is to instead meet the patient with the understanding that as your family, we understand that what we've been doing hasn't been working, and therefore we have to do things different. We have to step back, not to make your life more uncomfortable, but because at the end of the day, when we put our head on the pillow at night, we need to know that we are not giving you the resources you need to continue to spiral. We need to know that we are not a part of the downward slide, and in a worst case scenario where tragedy strikes, we need to know that we weren't a part of making that possible. And when the family steps back and puts the responsibility of life and the responsibility of the addiction on the individual, oftentimes that is enough to create the discomfort where someone wants to get help. Here's where connection comes in. First, there's a need to really understand the human condition of addiction and the immense suffering that happens inside of addiction. I've heard before, and I've said at various times, that addiction is a disease of isolation, and that recovery is a process of connection. Understanding the suffering that someone is going through when they're in a pattern of active addiction is the first step to being able to meet them and help them find their way out of it. The frailty and being face to face with someone that is in enough psychic pain that they're making decisions on a daily basis that harm themselves and put themselves in a situation where they are disconnected from their family, they're unable to relate to the people around them, and they are literally and figuratively dying. understanding that as we do this work, that is what we meet on our path. Finding the compassion and moving from compassion to guidance. So the first step in the intervention process is what we would call assessment. Understanding based on the clinical history. At times when we have someone that is resistant to treatment, in virtually every case, they are not going to be ready, willing, and able to talk to a clinician, a program, a therapist about what's going on with them. Some instances we have that opportunity, but in most instances the individual is going the exact opposite direction of help and unwilling to have any of those conversations. So getting a thorough and proper clinical history as best we can from the family system is paramount. Once we start to understand the pathology and what is affecting the individual and the family system as a whole, then we can start to put together what the appropriate clinical path is for them, the appropriate treatment plan. And the way that I like to tell families to think of the treatment plan in intervention is to pretend for a moment that whatever you asked your loved one to do for the next 24 hours, that they would agree to, they would follow through, and they would participate enthusiastically. What resources would we put in front of them? What path would we submit to the family and to the patient as a means for them to actually get better? The answer to that becomes the treatment plan. When we have a treatment plan and we still have someone that is resistant to treatment, that is where we really begin to connect with the family system. If you put me face to face with an individual struggling with addiction, and I was able to spend time with him or her to connect and understand what dynamics were fueling the addiction, what the underlying core drivers were, if there was trauma or co-occurring disorders, if there was insecurity, if there was underlying hurt. And I was to try to convince someone who was resistant to treatment to begin the treatment process. My effectiveness would be woefully low. My ability to move someone, meeting with them one-on-one in the midst of addiction, wouldn't be reliable, and it wouldn't be something that I would feel confident that we would be able to move patients into recovery. The approach, as I was trained and as I've seen practically unfold, the approach is the family system. The family system has the connection that the clinician lacks with the patient. The family system has, in most cases, decades and even a lifetime of connection with that individual. There is understanding, there is oftentimes, hopefully, unconditional love, there is history, and there is the intuitive understanding of what the individual is going through. When I can take that family system, when we as a program can take that family system and help that family system walk through the process, as we talked about a few minutes ago, of understanding what in their dynamic, what in their system has been working, has been helpful, and what in their system hasn't been helpful, what in their role individually has been helpful and what hasn't been helpful. When the family connects with me as a facilitator, as an interventionist, and the family has faith and confidence in the direction that I'm suggesting, when the family trusts that I know what I'm talking about, the family is then able to adopt and shift in the critical ways and shift in the ways that are necessary to move the patient to a place where they accept help. As I said, one-on-one with a patient, I'm ineffective. But when I have a family system that is able to understand and receive new information and understand that things that they do haven't been working and things that they can do will work. When the family gets that, everything shifts. Many of the family interventions that I facilitate, my time with the family system represents 95% of the conversation, 95% of the process, 95% of the face-to-face and the session work. Ultimately, in the intervention, there's a moment where you bring the subject of the intervention into the conversation. That is 5% of the work in many of the cases that I'm a part of. Not always the case, but more often than not. The reason why the family system is 95% of the work is for the reasons that I just outlined. Helping the family understand what hasn't worked and shift into what can work. It's easy to say in 2 sentences, but it is a very tall order. The family systems that have adopted, and I dare say, the dysfunctional dynamics. And again, the language that we use brings with it a connotation, and I believe that freeing the family from a feeling of guilt, shame, and responsibility is a key ingredient to helping them see this with new eyes. Family systems are at a loss. Family in and family out. We've seen thousands of families at Guardian, and families more often than not don't know how to navigate addiction and don't know how to navigate recovery. I've actually heard it said by one of the clinicians here when we were meeting with a particularly tough client and a family of a particularly tough client. The clinician said to the family, guys, our staff has been trained in behavioral health care, addiction treatment, and many of them have decades of experience, years of education, higher degrees, doctorates, and our staff has devoted every resource we have to move the needle ever so slightly with your loved one. It takes everything we've got to be effective or to begin to be effective. So where do you think a family without the education, without the professional experience, where do you think a family fares in dealing with active addiction? They're at a loss. And they're at a loss in a condition that is fatal and progressive and chronic. So helping the family system understand that there is a new way to do things is a tall order. But when we do so carefully, when we are able to connect, when we're able to earn the confidence of the family, and when we're able to gently, and I can't overuse that word enough, when we're able to gently guide them through the process, when we're able to acknowledge that what they're doing comes from a place of love, and able to acknowledge and get them to acknowledge that their interactions and their relationship with their family member comes from a place of inexperience and not being educated in addiction. When we can bring the family up to speed, everything shifts. 95% of the intervention process, as I said, in my experience, is with the family system and 5% is with the patient. And that is where, in most cases, 95% of the work is with the family. There is the moment when the family system shifts and they say that we can't do things as we have been doing things. Where that creates, and it's not lost on me or our team, that creates a crisis for the patient. if mom and dad are paying your bills, if your husband or wife has turned a blind eye to your active addiction for an extended period of time, and there comes a moment where they say, I'm not doing this anymore. There begins the crisis. The connection as it relates to the patient in that moment is critical, and that if I have connection, I'm able to present to the patient a treatment plan that can guide them out of the crisis that they're in. And I can present it in a way where it can be received. Much like the family system, when approached with wagging your finger and telling them that what they've been doing is killing their child, doesn't work. Telling an individual in active addiction what they have to do also doesn't work, in my opinion. What works is when they have come face to face with a crisis that the family system is no longer going to continue to support them as they are hurting themselves. However, here is a path. If you will trust us, here is a path to walk out of active addiction and into recovery, oftentimes through the threshold of a quality treatment program, but into long-term recovery. There is a way. There are people here to help you. There are people here to guide you on that journey. And if you trust us, then we have this path laid out for you. And when we're able to connect on that level, things unfold and patients agree to help. Treatment becomes accessible, resistance falls away, and someone can find themselves beginning that life-saving journey away from addiction, away from isolation, and into recovery and into more connection. It starts with that point of connection, and connection widens and deepens through the recovery process. At Guardian, we're grateful, and it is meaningful for us to be involved in that journey for families and for patients. I hope you guys can glean from this short talk how critical and fundamental the intervention process is for the very fabric of this organization. It not only was founded on an intervention practice, but the intervention practice for us continues throughout the course of treatment. Also, just because someone walks in the doors of a treatment program doesn't mean that they are committed for the long term. Sometimes that is an initial step, an initial point of trust, but the need for continued connection and continued intervention throughout the course of treatment and into recovery is necessary in many cases, and it's important to lay the groundwork with the family system prior to admission and continue it throughout the process. So thank you all for taking the time to listen. I hope that you have taken something from this. I hope in some ways that I can repay the favor that was given to me by so many outstanding professionals in our field, which is to guide me, to train me, to take me under the wing of the clinicians and the interventionists that have come before us, and I can in turn continue to pass this on to all of you, and thank you again.
Hello again, my name is Tommy McGee with the Immersion Recovery Center, aka Guardian Recovery Network. We're in the third and last day of our symposium, and I first want to thank all the facilitators that did an excellent job. You know, Kenny on the first day, going over and doing, I would say, a very detailed explanation of our clinical philosophy. Again, did a very good job. Anna Barrett and her helping us better understand the similarities between the 12 steps and CBT. Then we had Alexis that made us more familiar with co-occurring disorders. I appreciate that a great deal. Today, Josh Scott covered interventions and helped us become a lot more familiar with the whole process of interventions. I was impressed by John Post and what he said about language and making us familiar with how important it is that we be very aware of our language and the type of language that we use with the clients that we work with. And I would say for the most part, this has been a very good experience for me. And when I say for the most part, I have to admit that in some cases it's anxiety provoking to be in front of the camera, but I am extremely grateful for my colleagues and the work that they've done to make this symposium a success. And I appreciate you taking the time out of your schedule to virtually participate in our symposium. Today, I wanted to talk a little bit about boundaries. And with some intention, I wore my shirt that has faces on it that has to do with connection, in my opinion. And boundaries is a pretty dear subject to my heart, and the ethics surrounding boundaries. You know, there's some difficulty as it relates to the type of work that we do in the specific industry that we work in, and boundaries because of its close relationship with 12-step recovery and the various fellowships. I mean, depending upon the fellowship, there is an expectation that the people that share membership in those fellowships have close connection. And so to be a therapist, a clinical professional working in an agency and also a member of a 12-step fellowship, sometimes there can be some confusion about how we practice appropriate professional ethical boundaries, specifically for those of us who are governed by particular accrediting agency or licensing agency. You know, whether we be LMHCs, which is licensed mental health counselors that are governed by the American Counseling Association, or if we're LCSWs, which are licensed clinical social workers, or we have a certification in the state of Florida, which is governed by and monitored by the Florida certification boards. Each of those particular bodies has expectations as to how we practice or how we practice boundaries, you know, how we maintain boundaries. Some refer to those as dual relationships or multiple relationships, but others just talk about the various relationships that we have with the clients that we're working with. The ACA does not have a particular term for dual relationships. It just says that there are non-counseling roles and relationships and counseling roles and relationships. The FCB does refer to those multiple relationships as dual relationships. It is specific about us ensuring that those relationships never become exploitive, but that's as far as it goes when it refers to those particular relationships. But again, for us, there is this ongoing dilemma. It's like, how do we go about navigating the line between those two relationships? Because it is inevitable that a therapist will have more than one type of relationship with a person that they're working with, whether that be something that's unavoidable, like running into someone in a mall or the barbershop, not necessarily in my case, or at the mall, or at a PTA meeting or a grocery store. And how do we go about navigating those relationships, specifically with someone that I am in a current counseling relationship with? And so the boards do take that into account, but there are some possible problematic issues that we can run into in the cases of whether or not we should barter good for services with those clients that may have a difficult time paying for services, but we know that are in dire need for those services. Do we make a decision as to whether or not we can accept not necessarily gifts, but other products in lieu of financial payment Also, whether or not we can counsel a friend or a family member. I remember reading a book by M. Scott Peele that talked about how those of us that have been gifted with the ability to help, how unfair it would be for us to practice this skill set amongst people that we don't necessarily share blood with, but refrain from sharing that same gift with our family members. But again, it's still a line that we try to find ways to navigate. And how do we go about interacting with clients outside of our offices as well as inside the office? How do we go about interacting with clients? Is it okay to develop social or business relationships with clients? Again, these are all issues that we struggle to find ways to navigate. Because it's not as clear cut as it might sound. It's in the office setting. I know that those members of Narcotics Anonymous, not to pick on that particular fellowship, there is a tendency towards more affection in that particular fellowship. And so, what is the expectation with people that are committed to that fellowship? What's the expectation as far as their behavior is concerned within an agency such as this? Do we expect that they are to deny that part of their being, which is, we would say, a very important piece of who they are, and in some cases, one of the reasons why we value their partnership in our agency? Do we expect, or would we ask them to refrain from such a big part of their participation in the fellowship? The same in people that are in AA. The tendency to know that it is imperative upon their recovery process to engage in intervention on clients, on people that suffer with the disease of alcoholism. What would that look like after hours for someone who is a member of our agency? Which clients is it appropriate for that person to seek to intervene upon in the after hours? Should that have to do with whether or not that person is a specific gender, specific location, which could potentially be a rule that we would have as an agency? One of the things that we know is pretty clear is sexual contact between current as well as former clients. Both the ACA and the FCB have some pretty clear guidelines as to a time frame when it is, I hesitate to use the word acceptable, but I would say when it's not prohibited for someone to have sexual contact with a former client. The American Counseling Association sets that at 5 years. 5 years before a person can have any type of romantic contact with a former client. That includes both face-to-face, personal contact, as well as virtual contact. The ACA also mentions contact in a non-sexual form, in the form of virtual or social media contact. It again sets the time frame as to 5 years before we have any contact outside of the office with former clients. I know that question has been raised on several occasions about, at what point is it okay for me to allow or accept someone's Facebook friend? So again, according to the American Counseling Association, and I'm specifically speaking to those that are governed by that accrediting agency, it is a minimum of 5 years before we are to engage in or accept that friend request. And I know that the American Association of Social Workers has a more stringent rule as it relates to that. And their rule is lifetime. In other words, once a client, always a client, as it relates to licensed clinical social workers. And what I would like for you to think about, for those of us that are in 12-step recovery, what I would like you to think about is how that connects to our participation in the fellowship outside of the counseling agency, and specifically meeting attendance. and home groups. The home group that you're a part of, if you're a licensed clinical social worker, I want you to keep in mind that, again, the rules are pretty clear about, how you are to govern yourself when a former client or current clients in that matter, for that matter, are begin to attend and potentially join a home group that you're a part of. The boards are pretty clear as it relates to licensed clinical social workers and what steps you are supposed to take. And what they say is that you should find yourself another meeting. The other boards, the American Counseling Association and the Florida Certification Board, have a distinction that they refer to as unavoidable dual relationships. And what they mean by that is that there are some situations where there is an impossibility for me to remove myself. If I had children, and let's say my children attended the same school as a former client, they would not expect that I remove my child from that school, or that I don't participate in any after-school activities, that I'm not able to go to the PTA meetings. The boards do consider that an unavoidable dual relationship. If I'm at a restaurant and the server just happens to be one of the clients that was formerly in a treatment program where I worked, that there is not an expectation that I relocate to another table. I've actually had that happen before. And it's not an expectation that I give them a bigger tip either. In the case of you're walking through the mall, you make eye contact with a client, and I've had that question on several occasions, that you're in a mall, you're walking down the center of the mall, and you spot one of your former clients walking your way. I mean, you're yards away from each other, and the two of you make eye contact. The question always is should I speak, or should I not speak to the person? I mean, should I come off as rude, and not greet that person? So I happened to have that happen to me here in Florida. I was walking through the Boca Mall, which is extremely rare because I am not a mall fan, and I'm walking through the mall, and I happen to see a client on the other end of the veranda. And there are no stores on either side that I have any interest in sticking my head in to hide from this client. And I can see that he's with someone that looks like his parent. And as we're approaching each other, we make eye contact. He doesn't have a look of horror on his face, but he doesn't have this affectionate look that a person has when they can't wait to greet you. He has this plain look on his face, and to me it reads, "Please don't speak to me." So as he's coming, we make eye contact and we just pass each other. Neither of us say anything, which is, it's okay and it's understandable. Because I always think about, so how do you introduce me? How do you introduce me to someone that doesn't know me? How do you introduce me when it's obvious that we come from two completely different demographics? It's not as if the two of us are the same age, or we come from the same socioeconomic background. It's obvious that there is this disconnect between our backgrounds. So how do you introduce me to, again, someone that is unfamiliar with your history or your status in recovery? And I think it is reasonable for you not to introduce me. And I think that the ethical thing for us to do is to take that into account and leave it to the client to decide how that situation or how that particular event is to be managed. And the boards give us the autonomy as to how to manage those relationships. The boards also talk about how we manage the boundaries or relationships with friends or family members of people that we've treated. It sets the same time limit as it does to that particular client as to those relationships. It sets the same 5-year ACA, 2-year FCB, lifetime with the social workers. It sets those same time frames as it relates to what types of connections we have with those people as well, which again makes perfect sense if we are to establish healthy boundaries with the clients that we're working with. So how do we go about managing previous relationships? And when I mention previous relationships, so we have been in a relationship with someone that was not a client, and that person becomes a client. So, you're dating or you're married to someone, and that relationship terminates, and after that relationship has terminated, that person becomes a client in the treatment center that you're now in. So how do you manage that relationship going forward? What are the boundaries, the parameters now, as it relates to how you connect with that person going forward? I mean, the answer to that, unfortunately, is as if that person was, from that point on, that person is the same as any other former client. The boundaries, according to the ACA and FCB, are that you maintain now the same boundaries that you would have if that person had been just a normal former client. You manage those relationships the exact same way. The reason I say unfortunate is because I know that sometimes it's difficult to manage that kind of relationship. Again, I speak again to those of us, or those who are living within the spiritual expectations or lifestyles of 12-step recovery, where the fellowship and the relationships that we have, that spiritual connection that you have with the people that you've been working with, whether it be in a sponsor relationship, or simply a sober report, not simply a sober support, that those are ongoing relationships, and that the fellowship expects that once a person has been in an agency and comes out, that the family, the recovering family, greet that person the same way they had prior to their admission into treatment. But again, there is a guideline in the ACA and FCB Code of Ethics that has a rule in place for us to abide by and follow in those particular instances. But there is I don't want to call it an exception, but there is an amend within that has to do with extending those counseling boundaries. That there are cases where you can expand the boundaries that you have with people that you're working with. And the only caveat to that extension in boundaries is that there has to be some form of documentation as to why you are extending those boundaries and what exactly those boundaries look like. Let me explain why there is that caveat, so that if there is a case where, let's say that you are a licensed practitioner, and at some point in your practice, this person that you have extended this boundary to, you have continued or reestablished a relationship with someone that at one point was a friend of yours, went into treatment, came out, and you extended your counseling boundary, you re-engaged after they came into treatment, you did not adhere to that 5-year guideline that's in the rules, and so later in your relationship there was some allegation against you of some unethical behavior, some type of exploitation. But you had documentation noting that there was an extension of those boundaries and there were reasons why you extended those boundaries, whether that was connected to your closeness within the community, the fact that you both had children at the same school and you were members of the same PTA, or that you were both in long-term or in 12-step recovery, attending the same home group. As long as there was documentation noting, in other words, as long as you laid some foundation and some explanation as to why you extended those boundaries, then you would be able to use that documentation in order to combat whatever allegations were brought against you. Not saying that you would win that, but it would be evidence that you had established some reasons why you needed to change or extend the boundaries of that particular relationship. You're also expected to document when the roles within your professional relationship change, because there often are times when our roles change within a relationship. And the reason that that is expected, that we make that documentation, is for the same reason when we're extending or expanding the boundaries in the relationship, is so that if there are for some reason there are allegations, and allegations, I want you to keep in mind that allegations do not always come from the client. Allegations can come from someone that's disgruntled, that is familiar with that particular client. Allegations can come from a family member that may have issues with that client and know that that person is seeing you. But it's always good to safeguard yourself and have some documentation in place, just in case for some ungodly reasons there are allegations brought against you. The FCB Code of Ethics also includes a section on the exploitation of clients. FCB, or Florida Certification Board, refers to clients as consumers. The consumers of the product being the services that we provide. That exploitation has to do with, it can have to do with goods, it can have to do with services, and what I mean in relation to that is that a person can exploit a client for services that they provide. In other words, bartering goods and services in an unfair way. That person can exploit a client, of course, sexually. So the FCB has put a special section in to lay a foundation to make it clear about what forms of exploitation can potentially take place, so that we are aware of what the rules are. I mean, I think that one of the benefits to having a code of ethics is that it draws a clear line as to what my licensing board expects from me in regards to conduct and ways that I can behave. I would prefer to always err on the side of caution, and the only way you can err on the side of caution is by being familiar with the code of ethics and being aware of what the rules are. We talked a lot about boundaries, and I want to make it clear that there's two types of boundaries. There are two types of boundary crossings, because not every boundary crossing is a boundary violation. So let me make the distinction between the two. So boundary crossings often happen within the treatment process. I mean, often do we depart from the normal practices that we have with clients. Often there's different interventions that we have to implement with a client in order to bring about, whether it be an awareness of a behavior or to help a client cease a destructive behavior. So there's often times that we cross a boundary, making contact with a family member when a client is about to elope from treatment, and we know that what it takes for this client to reset from their state of denial and recommit to the treatment process is by being in contact with the family member whom they do not want to leave a relationship with. That is a boundary crossing. It's not a boundary violation. Because the difference is, a boundary violation is when a practitioner, a professional, misuses their power with the intent of exploiting the client that they're working with. So again, a boundary violation is when a practitioner uses or misuses their power with the intent of exploiting that client. So boundary crossings aren't unethical, is my point. They are a lot of times rooted in our care and concern for clients. So they're humane, and on a lot of times they're very effective. Again, boundary crossings are not unethical. Boundary violations are always unethical. So keep that in mind. Boundary crossings aren't unethical. They are In fact, they are unavoidable, inevitable in the work that we do. But boundary violations are avoidable and they are unethical. The same is with dual relationships. They're not always unethical, and sometimes they are necessary in the relationships that we have with our clients. A dual relationship, I may be a client's therapist, but in a hitch, I may need to be that family's family therapist, or I may need to be their case manager. So dual relationships are not unethical, and sometimes they are necessary. So some of the things that I want to make sure that I transmit to you is that multiple relationships with clients are inevitable, that they are unavoidable, that we are going to have multiple relationships. The piece that I want you to think about is, what is your motivation when you're about to enter into this dual relationship or multiple relationship? I want you to ask yourself these questions. Am I entering into this relationship because it's necessary, or is this a relationship that I should avoid? Am I entering into this additional professional relationship because it's necessary, or is it something that I can potentially avoid? Can this relationship potentially cause this client harm? Is there any likelihood that this behavior, that this relationship, that this intervention can potentially cause this client harm? I mean, if it is a maybe, you should avoid the relationship. You should avoid that particular intervention. I think that those of us that work in the field, we have developed this second nature, this intuition. We get this gut feeling when things are off. And so if you are at the threshold of making a decision about a relationship that you should engage in with a client, and you have that twist, that ting in your gut, then it's a relationship that you shouldn't embark upon. You should avoid it. Is there a risk that the dual relationship could disrupt the therapeutic relationship? Is there a possibility that me accepting this role with this client may harm rapport? Is there a possibility that it will change my role in this therapeutic relationship? In other words, is it possible that I could go from being seen as a reference point, as a therapeutic resource, to a partner or a friend? Although I know that it is important that we partner with the clients that we're working with, we should always maintain a space where we can be therapeutic role models, where we can be resources, where we can give guidance or accountability to the clients that we're working with. If there is ever a threat, that there's a possibility that role will be altered by entering into a different relationship, by making a different decision about a client, then it should be avoided. Am I able to evaluate this matter objectively? Am I able to evaluate this matter objectively? Am I able to maintain this connection objectively? Can I remain in this relationship and be objective? Can I still be a source of truth to this client that I'm working with? If there is any question, if I feel on any level that my emotion has become the primary source that I'm making decisions from, then I need to reevaluate the relationship that I have with the client. Then I need to reevaluate, reassess the decisions I'm making about this client. The greatest level of accountability is supervision, is having someone or a group of someones that you can discuss the decisions that you're making with and about the clients that you're working with, is to run your decisions by someone whose clinical skill set you have faith in and you respect, is to run your decisions by that person. Some of the safeguards or risk minimizers that we can utilize is just set healthy boundaries from the beginning. Just maintain healthy boundaries from the very beginning. I have this thing. I was trying to decide whether or not I want to reveal my secrets. I have this thing about hugging clients, period. Male or female. I'm very careful about at what stage of their recovery they're in before I hug a client, and gender, to be perfectly honest. So I try to set that physical boundary in the very beginning of the relationship with that client. And when I say relationship with the client, because I believe starting when we start to develop rapport, a client and myself, that I have established a relationship. That initial introduction is the beginning of that relationship. It's also important to involve the client in those boundaries, in setting those boundaries, whether they're professional boundaries or non-professional boundaries, by explaining to the client why you are setting up the particular boundaries that you have, so that both of you are held accountable and are clear about what the boundaries are. But with that, keep in mind that you are primarily responsible for maintaining that boundary. Let me repeat that. So you are accountable to that boundary. So you can involve the client in setting and maintaining the boundary, but you, as the professional, are always responsible for and will be held accountable to maintaining that boundary. So in the beginning of a lot of clinical or counseling relationships, we agree upon what's called an informed consent. And so what an informed consent does is that it clearly defines what the boundaries in the relationship look like. It explains, what my role is in the relationship. And it also talks about what practices I will use throughout our relationships. In some informed consents, it also includes the duration of relationship. So I know that we don't practice that with all the clients that we come in contact with. But if you would think along those lines, when you're engaging with clients in the early parts of their treatment episodes, if you would think about, what are the roles that I expect to play in this particular relationship, and how can I be assured that the client is aware of those roles and will be able to respect those boundaries. And I think that if we can keep those safeguards in mind, although it's, again, extremely difficult, and I do use the word extremely on purpose, difficult for us to navigate those relationships, maintain rapport, practice authenticity, live in a state of authenticity, I should say, and be assured that our clients know how much we care for them and what our intention is. Although that is extremely difficult to do, it's obvious, and we are obligated to do exactly that. A lot of the clients that we work with come into this space, suffering with a long history of broken relationships or difficulty in establishing healthy relationships. So it would make sense that people with that type of experience would come in with a need to attach to someone that cares. And with that in mind, it would be easy for someone to find themselves in a relationship that is not necessarily in their best interest. So it is up to us as the professionals, as the people with the training, as the role models, to be the ones that will set the stage for what a healthy relationship looks like today and ongoing. And I, again, appreciate everyone attending virtually all the days of our symposium. I look forward to us being able to connect again, either virtually or physically, once what's going on in our society starts to come to a close. And with that, thank you and have a great day.
Good afternoon. My name is Michael Freundlich. I am the Director of Family Services here at Guardian Recovery Network. I'm a Master's in Healthcare Administration, and I have been with Guardian for approximately 4 years now.
Okay, I am Michael Herbert. I have been working with Guardian now for about, since 2014. I facilitate the family workshops, and I do some individual work with clients in group and individual sessions. I've been working in the field of addiction for about 30 years. I've worked inpatient, outpatient, residential. I am an addiction counselor. I'm a certified intervention specialist, and I provide coaching and structured family recovery for individuals and their families.
Do you want to tell us a little bit about yourself and your experience working with families affected by addiction and alcoholism?
Yeah, I've been working with families all along in the field of addiction. When I first started, it was probably more to make the job easier. You call up families, you report to them kind of what their loved one is doing, and those kinds of things. But over time, you realize that the family has as many problems, if not more, than the person with the addiction problem. And, we just had to work more effectively with families. And working with families meant more than just kind of reporting to them what their loved one was doing or not doing in treatment. Mm-hmm. It meant that we needed to delve more into the family in what they're doing or not doing that can fuel addiction or fuel recovery. So how do you engage families in a process where it winds up being helpful for the family and the individual with the addiction problem?
Sure. Yeah. So why do you believe that so many families are so gravely affected by the addiction of their loved ones?
I think one of the reasons is most treatment programs treat the person with the addiction problem and not the family. They collect the money from the family to pay for treatment and ask families to pay for halfway houses and other services and get them cigarettes and things like that. But we're not really treating families. Now, families do get a phone call, but I don't think a phone call is sufficient for a family or a person that's been dealing with addiction for 20 years. And they get one phone call a week, where the person with the addiction problem gets 24-hour care 7 days a week for 30, 60, 90 days, sometimes a year, and the family gets one call. Families and people with addiction problems go through the same process. Families are negatively affected by addiction just like the person with the addiction problem. They've got headaches, they've got stress, they've got depression, they've got anxiety, they've got money problems, they've got sexual problems, they eat too much, eat too little, they miss work, they isolate from others, they become dishonest through enabling, and the list goes on for family members. But who do we treat? We treat the person with the addiction problem. If a family has gone through all of that, the trauma of addiction, why are they not getting an equal amount of help? Because if they get an equal amount of help, if we bring the family into recovery, that's going to change everything. It's always lopsided when you spend all your time with the person with the addiction. If I had my way, I would send family members into treatment for 30, 60, 90 days and leave the person with the addiction problem on the outside. And if we can get families to change, it really does force the individual with the addiction problem to change. Because without enablers, they can't continue with their addiction. So any good addict has an enabler, right? If we can end the enabling of the disease of addiction and only enable the recovery process, things are going to change.
Yeah, that's a great point. So what does it mean when people say that addiction itself is a family disease?
Well, because everyone is affected by it. And again, if that list I gave you of headaches, depression, anxiety, stress, memory loss, concentration problems, slips and falls, fender benders, all of those things are affecting families. Other family members are getting neglected because the bigger family is looking at the person with the addiction problem. And the belief is, if I can help this person with the addiction problem, everything will be okay. All along, everything else is falling apart. So the other children in the family or other family members on some level are getting sicker because the main focus is on this one person. And other people aren't getting their needs met. Generally, the precursors for addiction, or at least how I see them, are cultural, genetics, use before the age of 15, untreated trauma, and untreated mental illness. If all we do is look at drugs and alcohol and we don't look at that other stuff that's affecting maybe everybody else in the family except for maybe use before the age of 15, we're missing the boat.
Right.
So we have to look at all of this stuff. I also believe that we have to look at more than a 12-step process, that people can be helped by the 12 steps, but also need good therapy, psychiatric care if they need that, diet and exercise. And one of the big hindrances in recovery is smoking. So the effects on the brain from smoking match the effects on the brain from heroin or alcohol or other drugs. And if we don't address that, as an agency, we're in denial, families are in denial. So I do recommend family members to don't buy cigarettes for their loved one in treatment. I mean, that's just my thing. You generally can't stop people from doing that.
Right.
But if I'm asked, that's one of the things, because we have to look at this whole thing.
Yeah.
And it's not just about drugs and alcohol. We have to look at other areas in the person's life.
Sure.
Yeah.
Sure.
Mhm.
So how do you believe that the families will be able to effectively communicate the pain that addiction has caused within their dynamic?
Well, just like I said, if it were up to me, I would bring the family into treatment themselves. So if we can get families into a recovery process, things will get better. If we're only focused on the person with the addiction problem and not focused on mom, dad, sister, brother, wife, or husband, we're missing the boat. So what is it that a family member needs to do? On some level, it needs to match what the person that with the addiction problem is doing for their recovery. So maybe they need to get into their own therapy. Maybe they need to get into a 12-step support group. They have to start looking at modifying lifestyle behavior, getting support for them. Every family that I work with, I give them what I would call a family or recovery mentor to work with. Another family that I have worked with in the past that has been successful in engaging in a recovery process. So families need to engage in a recovery process to recover from the ill effects of addiction. Just like a person with a drug or alcohol problem has to recover from the ill effects of addiction. The mothers, the fathers, the wives, husbands have to recover from the ill effects of addiction. And how do they do that? Well, they do that in therapy. They might get involved in a retreat somewhere to do some of that work around, what the popular term is called codependency. But there's a lot of work that families need to do. And if we can get everybody on the same page of this process, the success rates are going to go much higher. Oftentimes families are left out and are presented with just kind of minimal concern about what's going on for them.
Right.
But if we can fully engage families in the treatment process, the outcomes are going to be different. And we have to look at this long term, that this is not just while a person's in treatment or 12 weeks after. If we can engage the family, and we're going to include the addiction process, the addicted person as part of the family. If we can engage those people for 3 to 5 years over long term, the success rates are going to go, out of the roof. They're just going to be great. Rather than this kind of hit and miss approach. We're going to put somebody in for 30, 60, 90 days, give them 12 weeks aftercare, and then forget about them. Well, what if they relapse? I would rather catch the relapse in a day or a week versus 6 months later. So if I'm working with someone for 3 to 5 years, if the person with the addiction problem starts to relapse, we can catch it early. If the family starts to relapse in old behavior, we can catch that early and address the problem. And that's how we keep people in recovery. So even if there is a slip, we can catch it so it doesn't turn into a full run where there's all kinds of damage that happens over long-term use, right?
Right.
And we probably are going to save money in that way too. So a person doesn't necessarily have to go to long-term treatment if they slip, and have a few beers or a joint or do some cocaine, over one night or something like that.
Right.
If they need detox, maybe they need detox, but we can get them back into outpatient or get them back into therapy. We can engage the family in the process, help them to respond better to a slip like that, and get them on track and get the individual on track. Get the family on track and the individual on
So
track.
it sounds like the focus for years has always just been on treating the patient, treating the individual, when in this case we're clearly understanding that the focus needs to be way more attention on the families and helping the families.
Well, we
to
want
recover.
to stop separating the person with the addiction problem from the family. It's the family. Everyone is in this family. There's no this one or that one. Because if you look at a family system, there are some people that aren't as well as others. And that doesn't necessarily mean the person with the addiction problem is worse than everybody else. There are people in families that aren't using drugs that are really struggling. And they need as much help as a person that's using drugs or drinking, problematically.
So how do you think that families can most effectively communicate with a loved one who's kind of in the grips of their addiction with, just that looming fear of the possibility of a relapse?
Well, the using the tools that they have, they're going to probably be ineffective. So if you can treat the family and help the family understand addiction, how they've been affected, then you can give them some tools on to help somebody else. But they've got to help themselves first. Just like, everybody says in the airplane, when the oxygen mask comes down, place it on yourself first, and then you can help others. So if families get some help first, they're going to be better able to help the person with the addiction problem. And if a family member is engaged in a recovery process with, let's say, a professional and a support group, they're going to be able to have those conversations more effectively because they can bounce things off their peers and not just rely on their own thinking. Right?
Yeah. So what do you think the most effective way is for families to set a loved one up for, long-term recovery?
So you keep talking about families doing it for the addict. What is the best way that a family can set themselves up for long-term recovery? Because if we can set a family up for long-term recovery, it's going to affect, if it's just the mom or just the dad or just the wife, just the husband, just the brother or the sister, it's going to affect the whole system in, I think, a positive way. So how do we set them up? Let's focus on the family. What are the needs of the family? And then address those needs. If we can address the needs of the family, it's going to have a ripple effect and affect the person with the addiction problem. So again, if the people around the person with the addiction problem change, it forces the person with the addiction problem to change.
Yeah.
If they're doing things differently, how is this person going to manipulate? If we're going to have Thanksgiving dinner at 3 o'clock, whether you show up or not, you're not going to ruin our Thanksgiving dinner anymore. That we're going to, and if you're late, if you're not invited. We're able to set boundaries. But we have to learn to, sometimes set boundaries for ourselves. this is what I'm not going to do anymore in response to you, versus setting up a boundary for them. I need to set boundaries for myself. You know, I may go overboard in helping, right?
Yeah, it's interesting because, again, the focus is always on the clients when the clients are in treatment, but the families aren't even, I guess, really understanding that it's themselves who not only requires the attention and focus in getting help, but also those boundaries. It's not so much how do we set our loved one up for success by placing boundaries for him, but it's also boundaries for themselves.
Right, so if family members identify their own relapse warning signs and manage those better, they're going to do better. But families don't necessarily even know what their relapse warning signs or triggers are. So we have to help educate families into what that means.
Right.
You know, if a mom or dad or wife or husband isn't taking vacations, I'm not going to leave the country because my loved one has an addiction problem, and if something happens, I want to be there. Boy, you know, I'm missing out on life waiting for a crisis to happen. You know, how long do I want to live that way? So we have to help families understand that, you know, maybe it is time for you to go on vacation. Maybe your son, daughter, wife, or husband might crash or burn, but, you know, they have my number and they can call me if they get in trouble. They don't have to solely rely on you to get better. We can give them an opportunity to kind of grow up and take responsibility for themselves. So if they get in trouble, you got to call Joe, the therapist.
Yeah.
You know, he's the one that can help you. We can't help you. We don't know what to do. You know, go to a professional. We're not professionals. What we're learning in our own therapy and our 12-step programs is to focus on ourselves. That we can't change you, but what we can change is ourselves and our response to you. So your crisis is no longer going to be our crisis.
Right.
We're going to be doing things differently.
Right, you're encouraging the families to continue living their lives, to continue pursuing their lives, and not putting everything on hold just in light of the struggles.
And it's a process. You know, so initially, I don't think a family is going to do that. But if you help families understand how they've been negatively affected and how this negative effect is affecting the whole system and the person with the addiction problem, maybe they're going to be willing to make some changes.
Yeah.
But we have to help people understand that. But we also have to help people. We also have to understand it's difficult. Change is difficult. So it's difficult for families to change. They've been doing things one way for a long time, even though it's not working.
Right.
That's what they're used to doing. So if we have them do something different, that's not going to initially feel right. It's going to feel like they're doing something wrong. But if we can help them do something different over and over and over again, it's going to start to feel right. It's just like if I ask you to start brushing your teeth with your left hand and you're right-handed, initially it's going to be difficult. And some mornings you're going to forget and you're going to struggle with it and you're going to say, screw it, I don't want to stop doing this. But if you keep at it, you're going to be able to brush your teeth with your left hand as easily as it was with your right hand. So we have to help people practice change over a long period of time. And when we do that, people do change and they instinctively know how to respond to situations that used to throw them off completely in the past.
Yeah. So I guess if you're speaking to any families that would be watching this, what would be some recommendations on how they could possibly identify in their own family dynamic that they've been affected by what's going on with a loved one?
Well, I mean, all you have to do is listen to a family when they call you, and they're going to tell you how they've been affected. And my job would be to just play back what they told me. When they're talking about the money and they're talking about the fear and what do I do, and I'm caring for my son or daughter's child. They're bringing drugs and strange people in the house, and what do I do with my grandchild? They're going to list all of what's going on, and you just have to play back to them, and you have to kind of wonder with them, how long do you want to continue to live this way?
Right.
And obviously they want to stop. And then you have to ask them, are you willing to do something different? Oftentimes they say yes, and they don't fully mean it because they don't really know what difference is. And we also have to help them with that process of doing things different. You almost have to hold their hand because, again, they'll revert back to old ways because that's what they're used to, or the fear will get to them and they feel like they have to do something to relieve themselves of the pain of what they're watching, right? And we have to help families understand that that their loved one can get through some things without their assistance or control, right? It's hard to imagine that they're going to go through something, but people with addiction problems go through things all the time without some guardian watching over them
Right.
and fixing it. You know, allowing people to experience the consequences of their choices is helpful. Rehab, what it does, rehab doesn't save anybody,
Right.
but it gives an individual one more shot at getting it. If individuals didn't go into treatment when they did, we don't know if they didn't, if they would have lived through that last run of their use. So rehabs are helpful in giving a person an opportunity, one more shot at recovery, helping them stabilize, and hopefully engaging families more fully in a process so they can be successful.
Very interesting.
Mhm.
Yeah. So I guess, is there any other message that you think would be important to communicate right now?
You know, when I talk to families, I do ask them, I give them some reading material. I ask them to participate in Al-Anon, Nar-Anon, or Families Anonymous just to go. I give them a phone number of a family member and I ask them to call. And then I ask them to call me a week later after they've done those tasks. And when they call me and say that they haven't, I let them know the resistance that you've displayed or the reasons why you didn't are going to be probably consistent with your loved ones, why they don't do the things that they're asked. So are you going to model healthy or new behavior for them, or are you going to model the same behavior they're demonstrating so they don't follow through and you don't follow through? They don't feel the need to do it, you don't feel the need to do it. But I'm telling you, based on what I do, that this way is helpful. If your way was helpful, we wouldn't be having this discussion. You wouldn't be coming to me for help if you had the answer. But for you to come for me for help and then reject the help that I'm giving you puts you in the same position that you were in before you met me.
Why do you think that they reject the help?
Because it's hard. Change is not easy. You know, so they reject it because it's hard. It's scary. Oh, you mean I have to let go? I have to not do so much? My self-esteem is built on me doing for others. If I don't do for somebody, if I'm a mother and I don't do for my son, that makes me look like a bad mother. I don't want to look like a bad mother. I've got to be in there helping him and doing everything I can. No, there are things that you can do that are different than that. You know, you don't have to go into action in that way. You can go into action in another way. So we've got to try something new.
And that action sounds a lot like the treatment of an addict, where, you know, if you're working with an individual and there's a lack of self-esteem or a lack of self-worth, they may be placing an emphasis on external things to help find that self-worth. So do you find in your experience it's very similar with the family dynamic, that they're almost recreating that same structure internally?
Absolutely. Yeah, absolutely. Yeah. Yeah. But, you know, I got to tell you, I have had a lot of success with families that follow a path. They follow a structure, that they're willing to do something different, and it makes the change. Anybody can do what they've always done, right? But it's when we do things different, when we do things that are difficult for us and then get past it, it opens up another world for us. Everything we do can't be easy, you know, and have real value. Some of the things that are difficult create a greater value, but we have to struggle with it first to get to the other side of it.
Sure.
Mm-hmm.
Sure. Well, thank you so much for your time today. I appreciate it.
Glad to be here.
Yeah, likewise.
Yeah. Okay.
Very good.
That's it.
Hi, my name's Amanda Eilola. I am a clinical supervisor at Immersion Recovery Center, and today I wanted to sit down and talk to you about de-escalation techniques, crisis intervention, and how to effectively communicate with your clients. A little bit about myself. I have been with Guardian for 6 years, since 2014. So I've seen us go through all of the amazing changes that we've been through, the growth, the expansion, all of the awesome changes, and I am thrilled and honored to be a part of it, first off. I've been in the field of addiction for about 15 years, and I've worked in every different level of care you can think of. And currently in my role as clinical supervisor at Immersion, I still work with clients on an individual and group basis, as well as providing clinical supervision to members of our staff. So let's get to it. So part of what I wanted to talk about is our clinical philosophy, and Kenny spoke on this the other day, and he has such a great way of making things accessible and practical and approachable. You know, for me, I look at our clinical philosophy being based on all of our collective years of experience. And really, you know, that's kind of how we got started at this thing, was some veteran people who had been in the industry for a long time came together and decided this is how things work best. So communicating effectively with clients who, you know, may have in their past had difficult histories, difficult, you know, time trying to achieve and maintain a life of freedom and recovery. You know, these used to get called treatment refractory individuals, meaning they have cycled through different programs and, you know, had their chance to do it over and over again, and for some reason still struggle. Here at Immersion, we understand how to work with those types of clients. We understand that they really, truly, on a basic level, are just unable to express themselves, unable to express their pain, their needs, and really don't even know what they need. They just know that they need our help and our attention. And that shows up in a number of different ways, like we talk about in our philosophy. And it doesn't always look pretty, and it doesn't always, you know, go doesn't always go smoothly. What I've also learned is that most of the time when you're able to sit with the individual who is having, you know, whatever issue or crises they're falling into, they're regretful, and they say, I didn't mean to act like that. I didn't mean to treat you like that. And I'm sorry, I lost my temper. So that's always just reinforces to me our philosophy, and also drawing off of what Tommy mentioned the other day in one of his talks was Carl Rogers and the idea of unconditional positive regard, meaning every person that we work with deserves fresh, positive, curious, compassionate interactions from us. No matter, you know, what they've done before they got here, or what they've done the 5 minutes before I open my mouth, they still deserve that respect and to be treated as a person who has value and dignity. And, you know, this is the way that we get the results that we do, which I think are pretty good. You know, I always try to remember that by the time somebody gets to this place, this is a life crisis. Nobody's here because they had nothing better to do. You know, and particularly with people who have had difficulty with achieving long-term recovery, how many people have been, you know, fed up with them or given up on them or said, we can't help you, we don't know what to do for you. and we simply never give up. And that's one of the things that I really pride myself on when I think about the work that we do. Our clients deserve better. We deserve better than saying we just can't deal with this whole thing. We have to respond differently than the people, places, and institutions in their pasts that said we can't handle this. We don't want to deal with this. So that's where I draw from in terms of what I bring to interactions with clients that are struggling and need some de-escalation technique and some crisis intervention. Let me go to my first thing right here. So basically, the goals for today are I really just want to talk about what happens with us when we become engaged in a client who may be behaving confrontationally, and what happens with them on a basic level, on a physiological level. I want to give you some practical tools that you can walk away with and feel like you could use in a real-time situation, and feel like you can keep yourself safe and the client safe, and then the surrounding clients and staff as well. And then after that, Tommy talked about burnout and self-care. I want to talk about what we need to do as professionals after having one of those interactions with a client that can be really stressful and light up all sorts of emotional and physiological responses in us. It's funny because we have situations happen here where even if we may be triggered by the same thing in our everyday life, if we are triggered by that here, we have to respond differently. So as long as we can get to the tools that I'm about to go over, I'm skipping pages here, so hold on one second. As long as we can get to that place where we understand how to regulate ourselves, regulate our reactions, then we're going to be able to project that calm, capable kind of energy that really does diffuse a situation and really help the client understand that I see them as a person with choice and a person who is responsible for making their own decisions about what comes next. Let me see if this works for me. So the first thing that we need to talk about is knowing ourselves and knowing how we react in these situations. Most of the time, if I'm working with staff or even thinking about my own responses to things, it's like, how would I respond? What do I normally do when I'm faced with conflict or confrontation? Myself, I fall into the same categories as every other human being and most animals on this planet, is I'm going to fall into a response that happens in my brain that I have no control over. So I want to talk about that for just a minute, just so you have a really, kind of basic idea of what happens in our brain that triggers off our responses to conflict. You've probably, or maybe you've heard about the different parts of the brain and what they do in the past. I want to talk about how we look at the brain in terms of evolution. So in the past, when we were running around out in the caveman times, and what we had to do was, protect ourselves, stay with the pack, learn how to survive and react very quickly to, whatever life-threatening circumstance or woolly mammoth was threatening to take us out, we needed to be able to react quickly without thinking. There's no time to sit and come up with a rational solution in these situations. So that oldest part of our brain, which is still the bottom part of our brain, I'm going to refer to as our reptile brain, our lizard brain, or basically just the base of the brain. Right at the base of the brain, there's this part called the amygdala. And this part of the brain is kind of our little scanning machine. This thing is always looking, hearing, checking, scanning, searching for threats and signs of danger. This is unconscious. We have no real interaction with this. This goes on whether we like it or not, because also this is the part of the brain that's regulating our basic body functions, our involuntary functions, breathing, our heart beating, those types of things. So, that part is going to be the thing that recognizes, oh, this client is confronting me. Here's this situation. So that part, what it does is it sends out a little distress signal, or a big one maybe, to the rest of the brain, and then that goes through the middle part of our brain, which I'll call the mammalian brain, and that's where all of our love and our affection and our emotional kind of lovey-dovey type of things exist. It filters through there, and then up to the neocortex, the part of our brain that's the part that we actually access. That's where our thoughts live. That's where we conceptualize and we think critically and abstractly, and that's where we would come up with plans. So the interesting thing about this is, back to that evolutionary design, when we feel threat, there is kind of a disconnection between that old reptile brain and our thinking brain. So imagine what that feels like, and you know what that feels like because I'm pretty sure everybody's been in conflict that's watching. That is that old part of our brain that doesn't think, that doesn't reason, that isn't attaching any type of emotion to, what happens next, is now in charge, because this blanket, this veil, this wall has gone up between our thinking brain and the rest of it. So what we need to do is be able to know ourselves and know how that changes first. How that changes what we feel in our bodies first. So, most people might be able to relate to this as a feeling of anxiety, a raise in heart rate, maybe breathing changes. You might feel a flush come about, because at the end of the day, again, your reptile brain is getting you ready to fight, to flee, or to, ultimately be able to shut itself down and freeze to protect itself. So in these situations, if you can recognize, that little change in your heart rate, your breathing, your body temperature, you're going to have the opportunity to respond differently than you might when you're not here or you're not utilizing these techniques. And these things are there for a reason, and they're helpful, and we need them. But sometimes it can get in the way when we are expected to have a calm, capable type of demeanor and project that we can handle the situation. So the next part that we need to take a look at is, how do I diffuse the emotional charge in this situation? How do I get a hold of myself, how I'm presenting myself, and how that then can influence the client that I'm working with to be able to mirror that back to me. So the first thing that I want you to do, instead of maybe your normal reaction, would be to say, I'm out of here, because that would be a lot of people's reactions when they see someone getting agitated, screaming, all the things that happen to us when people aren't able to regulate and they really don't have any other coping skills to deal. So we're not going to run out of the room. We're not going to get really big and start yelling back and, get threatening in our body posture like we might if we were out in some other situation. And really, even though we might feel like we want to, we're not going to curl up in a ball, and we're not going to freeze in light of this situation, because again, we're supposed to be the ones that are the calm, capable ones in these situations. So the first thing that I always think about, and this goes for really any type of situation where you're feeling this discomfort or your body is reacting to being confronted by a client, is start with your breath. That is, it almost seems too good to be true for this to be an answer and for this to be the way to manage these situations. But it is. And it can be the hardest thing to remember, because again, we're sitting there trying to figure out, how do I protect myself? But if you start with your breath, that will take you into a place where all of those body reactions that we talked about are going to reverse themselves, and the heart rate will slow down, and the breathing becomes more measured, and our body temperature will get back to normal, and we're going to be able to actually sit and listen and not react. While you're doing that, you'll get a sense of what's going on around you. And, it can be difficult when you've got a situation where there's multiple people around, and whether that's multiple staff members or other clients. The first thing after you've regained your sense of, okay, I've got my footing, the first thing that I always suggest is that you approach the client very obviously non-threatening, a lower tone of voice, something that's very measured and calm, and just kind of ask, are you okay? How can I help you? What's going on? Like, not necessarily what are you doing and you need to stop that and stop yelling, stop doing whatever they're doing, because that really, it just kind of intensifies their reaction and can really make the behavior worse. So at this point, it's our opportunity to ask, are you okay? Because at the end of the day, like I said before, that's what's happening. They're not okay. Their psychic pain is unmanageable. They don't know what else to do to get the attention, the care, and the response that they need. So, while you're doing this and you're kind of investigating the situation with your client, I want you to inconspicuously, obviously, assess the space that you're in. And I want you to look at the positioning. I want you to kind of look at your position in relation to this person. I want you to give yourself at least one arm length and maybe two in terms of space away from this person, so that your energy and their energy are not just bumping up against each other. This is easily accomplished in some situations and harder in others. The instinct, I think, that I'd like you guys to follow when you feel like you can't get enough space, and even if you can, the next move I want you to make is to ask the client if they would be okay with going to a more private location so that we can discuss what they need. And that always works best for me if I talk about it as a question versus we need to go in this other room or you need to get in there. Obviously, that doesn't go well. But really, like, can I take you somewhere private where I can actually hear you and listen to you and give you the attention and the care that you need? At this point, hopefully you've calmed down. Even if you haven't, you're still breathing and you're remembering to keep yourself going. This is when you really sit back and address the situation with the client with curiosity. Be a detective about this. Really try to figure out what is going on for this person and give them the space to vent, give them the space to accuse, to blame, to do whatever they need to do without reacting, without trying to defend your position or really the agency's position, and just let people vent out the situation. And then you're going to have an easier time getting to what it is that they think that they need. At this point, hopefully the other staff has heard what's going on and they've stepped in, and they'll be able to handle the other clients. So, you've got yourself in this location where a person feels tended to, they feel the attention that they crave and they need. And also it can decrease the possibility of them intensifying their behaviors. A lot of the time when people realize that they have an audience, they can get very performative and they can get very loud, and this kind of will cut that off. I think that once you get into that situation, you're able to start kind of negotiating with them about what it is that they need. One thing that's really important that I remember is to try and treat every interaction with a client like it is the first time that I've seen the behavior, the first time that I've had that discussion. I'm not going to recall past incidents. I'm not going to remind them, oh, like you're doing this thing again. I'm going to be very objective and really treat this as an opportunity to get new information. Next, I think the most important thing that we can do in most of our interactions with people in general, and also specifically our clients, is validate. I'd like you to reflect. I'd like you to repeat back. I'd like you to really just communicate. I hear you. I understand. Whether you agree with it or not, or whether you think what they're saying is unreasonable, as long as you're telling people, I hear you, I'm listening, I'm with you, you're connecting, and you have a better chance when you're connected to help somebody understand that, it really is our goal to try and help, to try and get people what they need. Another part of successful kind of negotiating a confrontation or a crisis situation Something I found that's really helpful is to remind people that they have free will, that they are autonomous, that they have a choice, that really they can do whatever they want to do. Because the more we try and put people in a box and restrict their behavior or their thought or their speech, the more agitated they become. Nobody, likes to be told what they can and cannot do, even if it's what's best for them. I find that staying out of the power struggle, even in these situations where it could be really easy to step in, is going to help people remember, okay, how I behave from here on out is my choice. I don't have to keep going with this because I started and, now I feel like I've got to go all the way with following through on, bad ideas that I might have had. People need to be reminded that while they have the free will and the choice to do whatever it is that they want to do, they can't necessarily always pull off those same behaviors while they're here or while they're with you in your office or in your agency. People need to be reminded that they absolutely are welcome to, do whatever it is, to leave treatment, to stop, attending therapy, to engage in whatever decisions they might engage in their personal life. But the natural consequences are going to occur. I can remind people in, sometimes in a reverent kind of way, like you can be as angry as you want, but you can't punch a hole in the wall. Like that's just not part of what we're going to be able to accept. So the next thing that you can do once you feel like you've established some kind of connection with that person because you've been able to regulate yourself, you've been able to, find out what it is that this person is really trying to communicate, and you've communicated back to them that you understand where they're coming from, that, they have a right to make the decisions that they want to make. But, there are expectations for them in whatever setting you're in. Then you can move into, trying to collaborate with them. And that really looks like, how can I help you get to what you need? Even if it's a bad idea. There are times when I will sit with a client who, a common situation working in this treatment industry is people saying that they want to leave treatment against advice. And it's something that people do when they feel like they're backed into a corner. They feel like their needs aren't getting met. They feel like they are so uncomfortable that they just cannot take it anymore. And even though most of the time they know that that is a bad decision, or even if they don't, even if their denial is so strong that they think they have everything figured out, they can benefit from a person allowing them to walk through that plan and, ask questions, kind of, how would you deal with this? You absolutely have the right to leave right now, but I'm worried that you don't seem like you have a safe place to stay. And really kind of getting through those types of discussions without saying that's a bad idea, don't do that. You need to just realize that you need to be here and you're going to stay here and forget about it. It's coming up with something that even if yourself as the professional knows this is probably not the best plan, at least it will buy us some time and it will de-escalate the situation because, again, the person feels heard. 9 times out of 10, we're able to turn those discussions around if we really can practice that person-centered approach, that idea of meeting a person where they are versus showing them where you want them to go. At the end of the day, a person is going to decide whether or not they trust you and they trust the system that you're working, that we're working in. And I find that treating people like autonomous adults can start that process easier than trying to put too much structure around them. Not that we don't have structure, but when we're in these situations, we have to be able to be a little more flexible. So if you come up with this and you're able to successfully kind of de-escalate the situation using those techniques that I went over, then I always try to make a plan that's not very long term. I try to make a plan that really involves maybe the next hour or so. And if someone's amenable to that, then I say, what about the rest of the night? Or do you think that this is going to help you get through the rest of this day? It's really hard for people in distress to think about a permanent commitment or a permanent engagement in a behavior that they're not comfortable with. Whether that is being compliant in treatment, whether that is giving up control or contact with family or access to, the autonomy that they normally have, whatever it is, as long as people understand that this is something that's their choice and that we're really just trying to work with them minute to minute, we have better results. I'm also going to ask my clients in those situations, before I just start telling them what I think, I'm going to ask them if they want to hear my ideas. Again, this engages them in understanding that I'm listening, I'm here, not here to impose my will, I'm just here to offer help and solution and possibly help them feel like they are safe and stable. So, if that's all gone well, which sometimes it doesn't, and that's kind of an unfortunate truth. Sometimes it doesn't. And we have to put or refer a client to a situation where these needs that they have can be better managed in a setting where they are safe and where they feel safer. Sometimes this is too much freedom for people in the setting that we work in. Sometimes they need a little bit more care and monitoring to feel like they can keep themselves safe and calm. We do have a highly structured treatment program, but at the end of the day, if someone is that dysregulated, they may require something additional. So after you have resolved that situation and however that went, whether that's successful and the person says, okay, I feel like I can handle the rest of my day, I feel like I'm okay with this, or I'm not okay with this, but I'm going to give it a try. I always make sure that they're back where they need to be. And then I'm going to check in with the rest of the clients. And I'm going to do that in a way that is, not ultra serious, unless it's just a situation that calls for that. But just a check-in. How are you guys doing? Everybody okay? I'm going to stick my head into whatever room they're in and just do a little bit of a scan just to make sure. If there's anybody in there that I feel like was also affected by the conflict or the confrontation or the crisis that occurred, I'm either going to pull them out or I'm going to find a colleague that can handle that. And that can be anybody from a clinical team member to a support staff member to, someone in the administrative office who happens to be walking down the hallway, because they've done that too. We work together. It's fun. So after I get that taken care of and I feel like all of the client needs are attended to, I am going to go to the rest of my team. And I will check with my support staff and make sure that they feel like they've gotten their needs met, they feel like they have a plan. We've debriefed any kind of reaction that they're having to the situation, and that they feel like they are calm and stable and ready to continue to care for our clients on the front lines as they do, so to speak. I'm going to also touch base, and if you're working in an agency situation, this makes sense, touch base with supervisors, touch base with other members of the clinical team that need to know what transpired. And I'm also going to check in with somebody on a personal level if it's something where I was emotionally affected, which again, I'd like to say that doesn't happen, but if you're in a confrontation, it can. Specifically if it's something that, involves, a situation that escalates, beyond something that we can handle here. One of the things that I love about being here and working at Immersion is the heart and the soul that our team brings to this work. And a natural outcome of that is sometimes having a reaction and a response to things that we need to talk out with other people. And if that means you need to say to your supervisor, I'm going to go take a walk around the building, I'm going to go grab a coffee, whatever it is that you need to do to make sure that you get the time that you need, make it happen. At that point, I would suggest that you make sure that you've debriefed, that anything is taken care of, that you feel like you can go back to your day. And even beyond that, you might want to pay attention to yourself for the rest of the day. And after that, if you need to talk to your supervisor about what happened, or if you're in a private practice setting, maybe call a colleague. I talk to colleagues of mine that are in private practice all the time for consultation to say, hey, do you think I did the right thing here? So that can be applicable in these situations too. Again, remember to ask for support, particularly if it is a disturbing situation. I unfortunately have been in situations where clients have become physically violent, and that's something that, it needs to get talked out. We don't see that here typically, but if you need to ask for support beyond that day, please remember that that is what your colleagues and your supervisors are here for. So Tommy McGee likes to call that putting a bow on it, making sure that we've wrapped up all the loose ends and that everything is taken care of so that nobody's asking questions about what to do next. So for me, I think that's everything that I wanted to go through in de-escalation techniques today. I hope that it was helpful, and I hope that you feel like you've gotten some practical tools that you can apply to your practice. Also, I'm the last presenter of the day and the last presenter of our Clinical Symposium, which has been, I think a really, really phenomenal experience. I have a lot of pride in the work that we do and our team here. I wanted to mention, first and foremost, it was really, really fun and informative and interesting to be able to sit in on Tommy McGee's talks that he did with us on burnout, on cultural diversity, on our culture, on ethics and boundaries. It is always my privilege and my honor to learn from him. He's one of my mentors, and that is what he does. He provides that calm, that energy that anchors our team and keeps us going in the right direction. I also want to talk about Kenny Silver and his talk on our clinical philosophy. Kenny really digs into this material. Kenny lives and breathes this philosophy. Kenny makes this philosophy approachable. He makes people understand on a practical level, and he makes this feel like something that is achievable. And I know for a fact that Kenny, one of his things is we do not give up on our mission to help people understand that there is hope and that they can recover. I also wanted to mention John and Anna and Alexis for bringing us more information on the power of language and co-occurring disorders and CBT and the 12 steps. All of their passion and their knowledge, their vast amount of knowledge and their experience is so valuable to us and really is the backbone of what makes our team our team. Not only their knowledge and their experience, honestly, but who they are as people and the energy and the heart that they bring into their work. I also wanted to talk about Michael Herbert and Michael Freundlich and their discussion. I have the privilege of working with Michael Herbert and facilitating the family workshop with him that we do here for Guardian Recovery Network at Immersion. Michael is he is dynamic, he is powerful, he is, somebody that I have learned so much from and hopefully can continue to learn from as we go and continue to do the workshops. And also Michael Freundlich, he's stepped in and he's been with us for years at this point, and he's always there to coordinate and be kind of that organizational person for us, and I really love his passion and his dedication to our clients and what we do. Lastly, I want to mention Josh Scott and his talk this morning, our founder. Josh and I have worked together, like I said, for about 6 years now, and we've done everything from run through airports together on intervention to sit in the office and really dig into how are we going to continue to find innovative, fresh, creative and compassionate care and solutions for our clients. Josh has a drive and a tenacity like no one else I've ever met, and it's that heart that beats through our organization on a daily basis. So I thank you all for taking the time to listen and to watch, and to hopefully you enjoyed and gained some knowledge and some hope, because at the end of the day, that's what we're here to communicate, that we believe that there is hope with every client that walks in our doors. So thank you.